see, listen, what will be the class today? It will be in the 3 parts. This is acute abdomen peritonitis. The first part I'll be taking is the A-type questions, single answer questions. The second will be the K-type, the true and false ones which are asked. And the last part, interesting part of this class would be some important last minute tips for you all who are appearing for this exam on the 4th of the April. Okay, so let's start with the class. I'll be reading the question and the answers. You answer it and then we'll see whether the answers are correct or not. Okay, so let's start. We'll start with the type A questions. The first one is, first question is, a 60-year-old man with a history of heart failure and reduced ejection fraction, COPD, requiring home oxygen and GERD, presents with dysphagia of solid and liquid food, which has worsened over the years. An esophagogastroendoscopy is performed, which reveals normal esophageal mucosa with negative biopsy results. High-resolution manometry reveals an integrated relaxation pressure of 20 mm of Hg, and a distal contractile integral, which is called DCI, is less than 100%. Okay, the esophagogram demonstrates a dilated esophagus with poor emptying of the barium. Which of the following therapies would be the most appropriate for this patient? The 4 options which are given as Nisen's fundoplication, botulinum toxin injections, esophageal pneumatic dilation, and last one is peroral endoscopic myotomy. Yes, please give your answers. You can put in the chat box. What do you think? What should be the answer? Not received any till now. Someone is saying D. Yes. Try to attempt it. See, in EDIC 1, there is no negative marking. So just try to attempt every question. Even if it is wrong, the marks will not be cut. So all the questions, make a choice ki you have to attempt all the questions. Leaving it will not be a D. Someone has again marked D. Let's see what the answer is. A bit of tough question this one is. Just 1 minute. So the answer for this is C. What was C? C was esophageal pneumatic dilatation. So achalasia is a primary esophageal disorder with the pathological consequences of degeneration of the ganglionic cells in the mesenteric plexuses of the esophageal body and lower esophageal sphincter of unknown etiology. Degeneration leads to insufficient relaxation of lower esophageal sphincter. So esophagography typically reveals esophageal peristalsis with proximal dilatation and minimal lower esophageal opening, resulting in bird's beak appearance. At present, achalasia is incurable and management consists of palliation of symptoms. In patients who are felt to be good surgical candidates, laparoscopic myotomy with partial fundoplication is effective strategy for long-term resolution of symptoms. So the one of the option was this fundoplication. It is a good strategy for long-term resolution of the symptoms. But however, the patient who are at risk of surgical candidates, the initial treatment with graded pneumatic dilatation is recommended. So that's why the answer for this has come out to be C, that is the pneumatic dilatation, and not POEM, that is the peroral endoscopic myotomy. Now, ruling out other options, we can see that the complete 360-degree fundoplication would exacerbate the symptoms of dysphagia and is not an appropriate intervention for achalasia. Botulinum toxin was one of the options also. It is an attractive and user-friendly approach which interrupts the release of acetylcholine from the presynaptic vesicles, causing an interruption of a neurogenic component, but has no effect on the myogenic components of lower esophageal sphincter. Okay. Although the initial 1-month response rate is close to 75%, the therapeutic effect wears off and approximately 50% of the patients relapse and requires a repeat treatment at 6 to 24 months interval. And the last option is POEM that we had saw. It is the peroral endoscopic myomectomy, is a novel methods of endoluminal myomectomy performed for traversing the esophageal mucosa. Although the technique is promising, it requires advanced endoscopic skills. In addition, POAM has been shown in 50% of the patients to promote further acid reflux. Okay, so the answer was C. Nobody got it correct. It was a tough question. Actually, I had kept it purposefully in the first because the exam is approaching. You're very close, almost you've completed your preparations. Such tough questions you will get in your exam. So you should be prepared for this. Okay. Let's go for the next question. Next question is a 65-year-old woman with a history of smoking and osteoarthritis is recovering well after a cosmetic plastic surgery procedure. Listen carefully to the question and try to grab the important points which will help you in the in getting the answer. Okay. On post-op day 2, she has resumed her home medications, including daily aspirin, is being prepared for discharge. However, she becomes newly hypotensive. She is transferred to the ICU with 1 liter of normal saline infusion and BP of 92/60, heart rate of 118. She is pale, diaphoretic, agitated. Her incision is clean and dry. Laboratory tests reveal HB of 6.5 from 12. Last checked 2 days prior. She had an episode of hematemesis and BP drops to 70/40. Transfusion of PRBC is initiated. Which of the following is the most appropriate next step in the management of this patient? You have to read very carefully the last line because the whole of the answer changes with the last line. There was the most appropriate next step, not the definitive, or it can be asked in the very different ways also, and the answer changes. The answers are: first is a stat CT angiogram of the abdomen. Second is interventional radiology consultation for angioembolization. Third is surgical exploration. Fourth is upper GI endoscopy. And fifth is transfusion, PRBC transfusion to HB of more than 10 with no further intervention. Yes, please give your answers in the chat box. Though it may be wrong, please, whatever you feel regarding this question, you put the answers in the chat box so that you should know what exactly is happening in this question. Yes, anyone can answer? Quite a straightforward question. Someone has answered B, that is the angioembolization. Yes, anyone else? We have so many people now. The exam is approaching. You try to answer, though it may be wrong. Only one answer, B, from one of the candidates. Chalo, let's see what exactly the answer is and an explanation why the answer is correct. Okay, just 1 minute. Yeah, the correct answer is D. D is upper GI endoscopy. Why upper GI endoscopy is the correct answer. Now, the patient with hematemesis becomes hemodynamically unstable because of upper GI bleed. Smoking, aspirin, NSAIDs, and osteoarthritis are the common, most important risk factors for the peptic ulcer disease. And in this case, the patient likely has an acute bleed from an ulcer. So up to 50% of peptic ulcer are asymptomatic until bleeding occurs, and which may present as hematemesis or melena. You all know this. So upper GI endoscopy is said to be a gold standard for this. Why? Because it makes a diagnosis of peptic ulcer disease, and it is also the first line therapy for bleeding ulcers. This should be performed urgently in hemodynamically unstable patient, as it allows both diagnosis and treatment. Out of all these modalities, the upper GI scopy is the only modality which will give us diagnosis also, which will be therapeutic also. And they have told that even in hemodynamically unstable patient, because many of the people have thought that the BP was shown to be 70/40. So with this BP, how can we perform the endoscopy? But in hemodynamically unstable patient also, we have to perform an endoscopy to ligate if varices or whatever can be done. If the bleeding stops, the patient will stabilize. Till that, nothing will happen. Ruling out quickly all other options. The CT angiogram is a definite, may identify source of bleeding. However, it is less sensitive. Surgical exploration with higher risk of complications than endoscopy and should not be pursued initially. If the endoscopy fails, we go for surgical. Angiographic embolization is an alternative to repeat endoscopy or surgical intervention, but does not replace the initial endoscopic management of upper GI bleed and higher risk of rebleeding than surgery. Okay, and transfusion of the blood products already has been done are essential in the early management of this patient with hypotension and evidence of bleeding. Although resuscitation goals for upper GI bleeding vary, restrictive strategies recommended. The transfusion for 10 milligram per deciliter is associated with higher rates of mortality. So what we get target is usually HB in upper GI bleed is, it is 7, not 10. Okay. So answer is upper GI endoscopy. I'll with a few of the questions, I'll be giving some latest and good guidelines which you can go through, which will help you in preparing the topic, because of upper GI bleed is a very important topic and few questions definitely will be there in the exam. So these are the ACG clinical guidelines of upper gastrointestinal and ulcer bleeding. If you get an access through the net, you go through this latest and very nicely explained all the latest guidelines. Okay. We'll going for the next question. A 55-year-old man with hypertension and anxiety. One more thing I want to tell, previous class also I have told you, if few of you can do this, because there are very large and big questions. In such questions, what happens is you read the whole question and then the last line. What you can adopt a strategy is you read the last line of the question and then the whole question. You get an idea of what things they are asking and you can grasp that things. Like, see, in addition to reviewing his medication list, what is the next step in caring this patient? You get an idea. Then you read the whole questions, you grasp what important points are there, and you can answer it quickly, because reading whole questions, you don't know what important points are to be grasped. Okay. Again, now going to the question, it's a 55-year-old man, hypertensive, anxiety, diabetic, recently adjusted his medication regime and began taking clonidine. He presented now with nausea and pain associated with occasional episodes of emesis of gastric contents over the last few weeks. His weight is unchanged. Vital signs are within normal limits. Physical examination, his abdomen is distended. Moderate tenderness is there in the epigastrium, but no rebound or guarding. His electrolytes are unremarkable. Sugars 350. Upper endoscopy and CT scan shows large amount of gastric contents with no evidence of mechanical obstruction, in addition to reviewing this medication, which is the best next step caring for this patient. So in this case, you have to diagnose what exactly it is. If you diagnose this problem clearly, you will get the answer definitely what the answer is. The next steps are given. One is you can put a Ryle's tube, nasogastric disc decompression, dietary modification and optimization of the glycemic control, PPI treatment, and then percutaneous gastrostomy tube for venting, or you go for surgical consultation for gastrojejunostomy. Yes, anyone wants to attempt? Any answer in the chat box? What exactly it is? If you get the B, someone has answered. Dietary modification and optimization of glycemic control. Yeah, anyone else want to attempt, or we'll see the answer? See, such tricky questions will be there in EDIC. Don't expect direct questions. B, very good. 2 people have answered it as B. So what exactly is the diagnosis? Anyone can unmute and tell?
Gastroparesis.
Yes. Chalo, let's see what the answer is. So the answer for this question is, it's B. Absolutely correctly told by 2 of the people. Dietary modification and optimization. What exactly it is? It is gastroparesis or delayed gastric emptying is occurring in this patient. It is a motility disorder in which food remains in the stomach for prolonged periods. This typically presents with postprandial fullness, nausea, vomiting, pain, bloating. It may be due to a variety of factors. Prolonged gastric emptying, including alpha-2 adrenergic agonist. See, in the question itself, first they have given the patient was started on clonidine. Clonidine is one of the drugs which causes gastroparesis. Narcotics also causes calcium channel blockers, TCAs, and diabetes medications also causes this. Diabetes mellitus is also a risk factor for gastroparesis. Only once the mechanical obstruction has been ruled out, the first line therapy gastroparesis is dietary modification, optimization of glycemic control, large meals, and foods high in fat and fiber should be avoided. Now, in this patient, ruling out other options. What 4 other options were given? First is, in this patient, there is no mechanical obstruction and there is no current complaints of emesis. So nasogastric decompression is unnecessary in this patient. Second was PPI. How we ruled it out? There is no similar ulcerative disease on his endoscopy and therefore no indication for PPI. Gastrostomy tube is very rarely indicated in gastroparesis and certainly not in this patient with recent onset of mild symptoms who have not yet tried lifestyle and medical management. And last one was the surgical, that is the gastrojejunostomy, can be used to bypass a mechanical gastric outlet obstruction, but will not improve the motility of this stomach. Okay, everyone convinced with the answer? Any doubt? Any point of time, you can unmute yourself and stop me and ask if any doubt is there in any question at any time. Okay, or at last we'll be taking the question separately also. We have to be a bit fast because the explanations are large. I have specifically put this large explanation so that the whole topic gets also covered. So any other question on the topic occurs, you can answer that also. Okay. Now the next question, a 35-year-old man with a history of chronic disease, Crohn's disease presents with foul smelling drainage from his abdominal wall. See, try to read fast and try to take the important points. See how I'm reading the questions. Drainage from the abdominal wall. He has experienced malaise, poor oral intake over the 3 weeks and is having worsening abdominal pain for 5 days. In the last 3 days, there is a swelling in the abdominal wall superior to the umbilicus in the area that began to drain foul smelling and greenish discharge. The area becomes erythematous, very tender. Drainage has increased volume over the 24 hours, develops fever, chills, dark urine. His vitals, temperature 102, heart rate 110, BP 95/50, respiratory rate 18, saturation 98% on room air. CT shows extravasation of small bowel that exists at the site of the drainage, but no drainable fluid collection in the abdominal wall. Now, what is the most appropriate management at this time? Okay. Second time I'm reading, what is the most appropriate management at this time? Now the 4 options they have given, 5. The first is take the patient to the OT urgently for exploration. Second is start broad spectrum antibiotics and monitor fluid and electrolyte status closely and nutritional support. Perform incision and drainage at the bedside. Percutaneous jejunostomy tube placement, initial tube feeding. Or last one is the consult gastroenterology for endoscopy. Yes. You can put your answers in the chat box. Anyone? B, someone has answered. Start broad spectrum antibiotics. Anyone else want to other one also? B, let's see what exactly the answer is. The answer is correct, B, because what it is an enterocutaneous fistula. Now, what exactly and what the treatment is? Patient with IBD presents with the enterocutaneous fistula formation. This often presents with prior operation, but can also appear spontaneously, particularly in patients with IBD. When the patients first present with ECF, they are often volume depleted, electrolyte disarrays and intestinal losses can have sepsis. I'll be fast because large explanations are there. We have to cover lots of MCQs in this. Okay. If you feel I'm very fast and not grasping this, please let me know. Okay. They require broad spectrum antibiotics and drainage of the associated intra-abdominal abscess if present. So this was the B was the correct answer, in which they have mentioned that you have to start the broad spectrum antibiotics, electrolytes and nutritional support. Okay. The patient should be started on TPN until anatomy of the fistula is defined and output can be controlled. The anatomy is usually defined by CT scan with enteral and IV contrast, with an added benefit of defining the undrained intra-abdominal fluid collection. In this case, the underlying IBD is the cause, and this patient's medical treatment treatment of the underlying Crohn's disease should be optimized. Okay. I'm reading further. We are ruling out the other options. It is not recommended to take the patient to the OT urgently. The majority of the enterocutaneous fistulas will heal on their own if needed, and surgery should be performed or delayed when the patient is well resuscitated, nutrition is optimized, and intra-abdominal inflammation has subsided. In this case, incision and drainage is not needed as there is no drainable fluid collection. We had seen in the CT scan, there was no no fluid collection was there. Okay. Percutaneous jejunostomy tube would not be appropriate before fully defining the anatomy of the fistula. And the last option was, in this case, neither upper GI endoscopy nor colonoscopy would be beneficial, as we suspect the fistula to be located in the small bowel, and there are more effective methods for localization than better depict the small bowel. Okay, everyone convinced?